We have Frank Price, who's going to tell us what we should do when we have an endothelial graft failure, options and outcomes.
Thanks, and I'd like to recognize my co-author, Matt Fang. No relevant financial disclosures. So when we talk about endothelial failure in our grafts, there's a number of causes for that, and these are, I think, the four most common. The age of the graft, glaucoma, especially if they have tubes or other filters with PKs, just drops alone contribute to failures, rejections, and chronic inflammation. So if we're going to talk about endothelial graft failure in our PKs and EKs, I think it's important to put this in perspective. So in 2018, we did 48,000 PKs and EKs in the US. And just taking roughly the survival is probably about 20 years for a corneal transplant, plus or minus 10. We could very easily in 2038 have 25,000 regrafts for endothelial failure. So that's just something to think about. So as I was putting this together a couple weeks ago, I looked at the number of regrafts we had in our practice between Matt and I over the last 3 months, and this is probably a little bit higher than usual, but we had 21 regrafts. Only one of those was not for endothelial failure. If we look at the time from the last graft to when we had to do the repeat, it ranged from 2 to 35 years. So that gives you an idea that, yeah, if they're old, they can fail. The original diagnoses were 29% keratoconus, 29% Fuchs, only 14% were from glaucoma only. But when we look at the causes of failure, a third of those were related to glaucoma, which I think is something we're going to be dealing with more and more. Only 19% had a documented case of rejection, 43% were just endothelial failure alone. The original grafts were primarily PK, but if we look at the new grafts, they were primarily DMAC. Almost half of the new grafts were DMAC. So what are our options for endothelial failure? I've kind of listed them here, DMAC, DSEC, PK, and then distantly K-pros and Gunderson flaps. So these are the questions I think we need to ask when we have someone come in with graft failure. And first of all, how successful can we be with a new graft? If that patient's not going to come back or take their drops, then you might as well just do a flap to make them comfortable. How clear is their stroma? How acceptable is the refractive effect in the ocular surface? If they're not acceptable, do a PK. Is the anterior chamber formed enough for an endothelial keratoplasty? If not, do a PK. Is the eye hypotenuse? If it's kind of mild, like a pressure of 7 or 8, then you can do DSEC. If it's really a fairly significant hypotony and it's your only eye, then I do a PK. So why is DMAC our first choice that we go to? As you've heard already, it gives us the best vision, the least risk of rejection, the least amount of topical steroids that are needed, so we have less secondary glaucoma and less secondary ocular surface disease. But there's more questions we have to ask. Are there problems we have to fix before we do this graft? IOLs are a big issue. If they have to be fixed or be replaced, we like to do that a month ahead of time and then do endothelial keratoplasty. How about tubes? Are they too long or poorly positioned? If all we have to do is trim them, we'll do that at the time of the regraft. If we have to reposition the tube, then we do that a month ahead of time because very often you get hypotony when you reposition the tube from the old track. If they're aphakic, if we're going to leave them aphakic, we can do a DSEC. If they are going to have a sclerofixated IOL, then we'll do that a month ahead of time. And vitreous prolapse can be done either at the time of the procedure or earlier. Now, these are 3 patients I saw over the last 3 months. The one up above was a 12-millimeter graft, and this is actually post-op after we did a 9-millimeter graft, DMAC. But we thought we'd have a lot of room, but as you can see, even though the angles are open, if you look very closely here, you'll see the angles are actually gone on both sides. It was a very inflamed eye from acanthamoeba and took a large diameter graft. This is a patient that went somewhere else for their glaucoma surgery. They came back and said, gee, since I've had my surgery, I have double vision. Why is that? And you can see why. And then this was someone that over a decade ago, we did an artificial iris that was now on the retina. And so we had to go in and lift that up and fix that before we could do another DMAC, or DSEC rather. Now, primary graft failures with EK, especially if you're beginning to do DMAC, are frequent occurrence sometimes. We didn't have any in the last 3 months, which was nice, but what do you do when you get one? Well, if they don't clear by a month, we recommend going ahead and repeating it with a new graft. We actually have shown that if you look at the visual results for regrafting a primary failure at a month, that the visual results are just as good as a primary graft that has no problems and clears immediately, as compared to previous reports that if you wait 6 months, the visual results aren't as good, and that's probably because of changes in the stroma. Then what about EKs under PKs? Because we're doing a fair number of those now. And they're more complicated primarily because of the irregularity on the posterior surface of the cornea. So it's important to look at that posterior surface. It's important to look at the diameter of the old PK. And I would strongly recommend long-acting gases in these cases. Now, in 2011, we reported our results for DSEC under failed PKs. And what was surprising was that the only risk factor for failure out through 4 years is whether they had a tube or a shunt or any type of filter. And as you can see, at 4 years, the survival rate was only 22% if they had a glaucoma filter, but 96% if they did not. And that's a big difference. Why do we think that's happening? We've gone back and looked at anterior chamber fluid, and what we've found is that the protein content in these eyes is very different. The control eyes in this study were eyes having routine cataract surgery. If the eyes had an express shunt or a trab, then the protein content was 5 times higher than normal. And didn't matter what type of tube they had, but either an Ahmed or a Bearvault, the protein content was 10 times higher. And we think that that's the reason the grafts don't last so long in these eyes. And then we also more recently published this year a series of DMAC under failed PKs, and pretty much the same thing. If they had a prior trab or a shunt, the survival rate was much poorer than if they didn't. And you can see that here. Now, the other thing that's important to remember is when you're going to be doing EKs, especially DMACs under a failed PK, you have to take into account that you're probably going to re-inject air more often. In fact, we now recommend that you use long-acting gas in these cases. So in this series, 25% of the eyes require 2 or more air re-injections. So why does that happen? Well, just look at this case. This is probably one of the, if I can get my pointer to work. But you can see the edge of the PK wound is very distorted here. And it's hard to get the DMAC graft to fold along that. So we actually found that if the graft was oversized, larger than the PK, we had to re-inject air 53% of the time, whereas if it was the same size or smaller, it was only about 1/3 of the time. So we can do DMACs and DSECs under these failed PKs, but it's more work. But then again, as Mark pointed out earlier, if they've been happy with their vision, then you should be able to give them that same vision back. And thank you for allowing me to come today.